affecting the gut, in particular affecting the bladder, in particular affecting what we call the abnormal release of histamine. Now, many of these patients go to many doctors, different specialists, who cannot put these together, and therefore they come under this marvelous diagnosis of what's called medically unexplained symptoms, which in a way doesn't tell you anything, and quite often, and sadly so, the serious side is many of these patients are sent to psychiatrists when they don't need to be sent to psychiatrists, and some can become quite embittered with the profession as a result. So how have things changed? It's true, we've been whistling through things in the 70s, so there's really no autonomic laboratories then. Spinal injuries came up, then the neurodegenerative disorders where there's failing neurons, then the intermittent disorders in the 90s, in the new millennium, the postural tachycardia syndrome, and now the other autonomic syndromes in association. And in 2012, I've just put that in there, this is a charitable trust which is to clearly increase research into prevention and cure, but also to raise awareness, not amongst the public specifically, but amongst our own profession, because there are quite a lot of people in medicine practicing, and of course at an undergraduate, who are not taught about the autonomic nervous system and problems. So I come to the last bit of my talk, which is, does autonomic medicine have a future? And I look back upon this and I thought, my gosh, how time has flown, you see. And I just give you a few sites which it shocked me a little bit, because I was first appointed a consultant in 1982, and that was at St. Mary's. And in 1982, Princess Diana gave birth to Princess William at St. Mary's, the private wing called the Lindo wing. And I think Lindy was there too. We were on the right and clearly trying to take pictures, but there were too many crowds. This is taken from more official photographs. So that's 1982. And in my first wave of sort of semi-retirement in 2013, when I was spending far more time because I was a senior consultant working in the Lindo wing, it did come back to me. This was 30 years later. There was now the little Prince William, now the big Prince William, and their Prince George, now the little Prince George. And 30 years had really flown by without my even realizing it. It also talked about continuity, but also change, because you see the difference even in the attire which they're wearing, as it were. And of course, coming back to this question, I thought, well, Emerson's famous quote, you see, life is a journey. I know it's sped fast, and maybe I've enjoyed myself, and it's not a destination. But we really do need figures in science, so we do need to find out exactly what has been achieved, what's happening. And so I just look back at some data. This is taken from our joint units. And if you look in the 80s, when we started keeping records, there were less than 500 patients tested. In the 90s, this doubled. It might not look a lot because of the syncope and the technology. And in the new millennium, it's gone up and up and up and up. I don't give you the figure, the latest ones, they're right up here. And we've got huge waiting lists. So sometimes with success, you've got the problems also which emerge, but the numbers of staff are being increased steadily. So a whopping great change over this period. Why do I think it's going to increase further? Because of the changes in autonomic neurovascular technology. Now we're doing joint work with Professor Lord Darcy and Professor Yang, who head bioengineering. This shows you a Bluetooth device. You can put this on the ear and you can measure heart rate, temperature, activity. This is a camera where you can measure diet and the rest. And the big advantage is by telemetry, you could be sitting at home and looking at all the data. So sitting with your son, in my case it would be grandson, looking at all this information. It could be right across the world. So these advances are going to change things even further. And then I talk, and I'm glad, Mr. Srinivasan, I asked you about this, about HGVs, you see, but these are high growth and volume areas. I've only talked about because we've had to focus on syncope, on POTS, and on Parkinson's disease. We haven't really touched the huge volume areas, one of which is diabetes. And Dr. Krishnamurthy pointed out that 20% of them now may have an autonomic problem, and certainly a neurological problem. And of course, an area I take an increased interest in, which is the elderly. Again, there are 125 million in India alone, and these have a number of problems with falls and so on, and autonomic problems. So there's really a huge, huge, huge area or areas to be studied still. So, can I answer the question? And the answer is I hope I can. Autonomic medicine, I think, is a super specialty within the clinical neurosciences. It's reductionist, but the advantage is it brings together other specialties such as neurology and cardiovascular medicine. It's important for both diagnosis and treatment because they are evidence-based, and that's very important these days. Integrative medicine is essential, and I think holistic care is really the key to this. It's for the benefit of our patients. So I really am very glad in a way that I followed my instincts partially. I continued in this field when there didn't appear to be a field. I think it's got a future. I think it helps a number of patients, and I'm pretty sure that it's going to go and continue and grow stronger and stronger with a lot of young people in the field. So on that, ladies and gentlemen, thank you so very much for listening and giving me this opportunity.
We have a tradition of questions after the oration, so very happy for people to introduce themselves and to ask a question. I would request people not to make very prolonged comments.
There's a gentleman there.
You need a mic here. You can step up to the mic there, sir. There's a mic in the middle, in the aisle. Please use the mics in the aisle.
In addition to the government's Made in India, the lecture by Made in India is well, got to be appreciative lecture, sir. And more than that, let me begin by thanking you for arranging the interview for a fellowship, which I discussed with you across the Atlantic with Professor Ridwan Sabshai, if I am correct here. The question is about the mortality, the future of individuals with autonomic neuropathy. In diabetes, of course, where we have multiple pathology, the mortality is for five-year mortality is very high. How about in your other, of course, maybe because the widespread disease, but here in your pure neurology autonomic neuropathy, the mortality is as high as the diabetic individuals or less than that. Let me complete by requesting the TAFE that if let them compete with the TBS in funding diabetic research more than the neurology research, so that you can come again and give a lecture about diabetic autonomic neuropathy. Thank you.
Thank you for your question, which is a very important one. I think in some of these conditions, if I just point out one, that's the autonomic mediated syncope. If you get it right, then the prognosis is very good. So you either put in a pacemaker or give advice or give drugs and so on. And in fact, I usually tell my patients that you're almost undoubtedly going to outlive your doctor. It depends on the age of the patient and the doctor, of course, but the prognosis is very good. Now, quite often, it's the underlying disease which dictates the prognosis. So in diabetes, as you say, it could be the associated comorbidities which are going to cause problems, possibly multiplied by the autonomic problem if not detected and treated appropriately. And the same with Parkinson's, as has been noted. So I think it's a combination. So there's no easy answer, but there's good news if you can detect and treat as quickly as possible.
Excuse me, sir, one doubt. Suppose, is it toes moving when you sleep, when you're in deep sleep and toes vigorously moving? Is there some relation to that? When you're in deep sleep and your toes move vigorously.
Moving toes.
Oh, I see. Moving toes, yeah.
Vigorously moving and you're deep asleep still.
Well, there have been a number of studies on various movements which occur, rapid eye and other movements which occur, and the relationship to neurological and other disorders. We've certainly not studied it or associated it in any specific autonomic condition. So I think the answer is that you can reassure your patients for the moment. We don't know, and therefore let's assume it's going to be all right.
There is also the syndrome of painful legs and moving toes, which we are all.
So is there a correlation between them?
Correlation with
painful legs.
So there is a condition where people have painful legs and they move their toes involuntarily, especially in sleep. We can talk about it offline.
I am Dr. Chokkalingam. I am a cardiologist. I really appreciate Mathias. How often you are successful in treating them? suppose we are going to take 100 patients, what is the success rate? Is there any failures in giving the treatment? Are you going to fulfill your treatment to all the patients, or some they escape your treatment?
Oh, yeah, thank you. You ask a question which you've got to realize that we run a very, very specialized center with patients coming from all over the country, certainly, and from many parts of Europe and the world too. So we're usually seeing the most difficult patients, as it were, rather than, the simple ones. But it depends upon the underlying condition. In those where there's damage to the autonomic nerves and the neurons, the chance of reversing it is pretty well zero. It might change with stem cell therapy and so on, but at the moment it's more, well, palliative is the wrong word, but we're helping them in terms of giving them drugs and other procedures to help them in life. It's not curing them like Alexander Fleming would have done with a 7-day course of penicillin. So that's that. And as we indicated, it's the underlying disorder which may be the prime factor causing not lack of success, or even failure, but causing the morbidity. So we try, and people vary. There's a lot of variability, and one of the key things is that we work on patients on an individual basis, because there are so many factors, which, as you've noticed, cardiac, hormone, clearly the autonomic nerves which contribute, that people vary. So there's no easy answer to that. They are individuals and they're treated as such.
Another comment that may be useful for the audience, and you must be aware of it. Many diabetics, they will have autonomic neuropathy. Mm-hmm. They will have sinus tachycardia. The sinus tachycardia more than 110, mm-hmm. if it exists more than 3 to 6 months, that itself results in tachycardia, cardiomyopathy.
Yeah.
Irrespective of diabetes producing. Now, luckily, last couple of years, because they are independent of autonomic, you have got funny channel inhibitors, that is evobred. They're supposed to be very useful sinus tachycardia. Thereby, irrespective of the response of the neurological one, they really benefit by reducing the heart rate in diabetes.
You raise a very good point. That's the new drug, ivabradine, very useful in tachycardia. And in fact, we use it in our patients with POTS who do not have diabetes. And again, from my knowledge of my colleagues in the different disciplines, it's the underlying disorder which can really cause the problem. So some of these patients, the tachycardia is an indication that there's widespread involvement, not just of the nerves, but the blood vessels and so on. So that's what can contribute to the heart attacks and so on. Our younger people don't seem to have that problem, but they don't have diabetes either.
Dr. George, unexplained tachycardia or unexplained bradycardia, no comorbid or no other problems. How will you treat them? In other ways, they are all right. They're normal. They're normal, healthy people.
Okay. I think we've got to define, that's assuming the tachycardia has got a postural component, that there's an autonomic component. There's a whole range of approaches, non-drug measures and drug measures which could be used. I think with bradycardia, I often get, if not usually, get the views of my cardiological colleagues to make quite sure there's no underlying primary cardiac conduction deficit. And so a bradycardia alone is not the usual sort of patient that we see. We do see some. In fact, I thought at one stage I might see somebody called Bjorn Borg, he used to have a heart rate of 38 beats per minute while he was winning Wimbledon. But I don't think he needed any help at all, you see. So I think one's got to get our colleagues' help.
Professor Ramaswamy, and then I'll come to the gentleman in the back.
So thank you for an awesome lecture. Can you please touch upon motor neuron disease?
Thank you. We have studied patients, and others have, of course, with motor neuron disease and ALS. And they don't seem to have any specific autonomic involvement. In fact, most of it is linked to the respiratory features which occur, because, as you know, the respiratory side can fail, which is when they get the secondary autonomic. Now, it's a good question because we've had a few patients who've had poliomyelitis. and this is quite severe. And poliomyelitis does affect these neurons too, and they have later developed autonomic failure of a very aggressive form. So the question has been raised, in fact, could there be a relationship which we are not seeing? Could it be that in motor neuron disease, they're, in a way, sadly so dying, shortly enough so we don't pick up the autonomic problems in a major way? So it's an unanswered question as yet.
Professor Ramaswamy.
I'm Dr. Ramaswamy. I'm in my 91st year now.
Well, congratulations, sir.
So I wonder if Dr. Mathias is related to Dr. Mathias, who was professor of anatomy in St. John's. So I took over from her. That's beside the point.
Oh, Mathias, yes, yeah. Mm-hmm. Oh, am I related? That's the question. Yeah, there is a relationship, yes. Not very close, as it were, but you're absolutely right.
So that's number one.
Okay.
So University College London remind me of Professor R.J. Harrison. That's another one. Now I want to come to the subject proper. Should autonomic nervous system should always be autonomic? Can it not be brought under somatic control, voluntary control? Yogis do that, and I can share my own experience with control of the autonomic nervous system. It takes about a half a minute. About 3-4 months ago or 5 months ago, I was having my breakfast, then I had a mild precordial pain. Mm-hmm. Then I checked, I had extrasystoles and missed beats. So I was just wondering, I did not rush immediately to a cardiologist and then try to do that. So after that, I kept regular record of my pulse of every day for three or four times a day. And then I started talking to my heart. I said, why do you want to have all these problems? Why don't you be regular in your, after about 1 month, 1 or 2 months, all the missed beats and they disappeared. And my pulse rate is only about 62, and my respiratory rate is only about 9 per minute. So that is number one. Secondly, people have problems with the lower end of the gastrointestinal tract, the terminal portion, and they complain of so many problems. Is it not possible to, I have myself trained my lower end of the gastrointestinal tract to respond to suggestions and act at the appropriate time so that I'm not embarrassed in certain situations. So is it not possible to, say, syncope, for example, postural hypotension, postural tachycardia, through yogasanas and things like that, is it not possible to postpone the evil date? It will come sometime, after old age and all that. Is it not possible to postpone so that younger generation does not get it?
Thank you, sir.
Can I answer that, if you wouldn't mind, very briefly? The first is congratulations on your 91st year, and I hope I'll be around to congratulate you on your 100th. And on that note, would you mind volunteering? The maximum was a neighbor of ours who came up for autonomic testing at the age of 99. I haven't yet got a 100-year-old subject for testing. So if you can do it, sir, I'd be really delighted. Coming back to your question, even though most of it is autonomically controlled, there is a volitional component, obviously, in our bladders, in our bowel. Most of the time, you're not thinking. And you're absolutely right. At the meeting in NIMHANS, one of the key areas was how could we combine, as it were, which is what you're doing and, already, some of the ancient medical and other traditions which will help introduce greater central voluntary volitional control over autonomic function. So thank you very much for raising it. But please don't forget the 100. Okay.
Thank you.
I think we'll take one last question from Professor Kamakshi.
Thank you very much again for an extraordinary lecture. Just extraordinary. Now, hereditary sensory autonomic neuropathy. This manifests with both sensory signs and autonomic signs, and it is hereditary. So then, Now I think I'm audible.
Yes, we can hear you now.
HSAN, hereditary sensory autonomic neuropathy. So if present, say in the proband, to prevent it from going on to the next generation, would you advise any form of therapy, like stem cell or any other newer drugs?
Thank you very much. You raise a very important question in some and many genetically introduced disorders, the hereditary disorders. I don't think there's any real therapy other than, I keep calling it palliative, but in terms of, helping with, so in somebody who's got the disease, I don't think, I'm not even sure whether stem cells would help, but that's really not an area I'm the right person to ask, as it were. What is clear is that from the next generation, I think there's a lot of work going on. You're probably aware that in the UK, there's a question of also whether things are manipulated, not just between the father and the mother or the couple, but bringing in a third component, particularly in mitochondrial disease, so that you can help the offspring. So I'm very sure that some of these basic science things, assuming they clear the ethical and other hurdles, are going to come in. At the moment, I think it's not as rosy, sadly so, other than helping with the condition.
Thank you very much.
Thank you.
Thank you. Senior citizen, one last question. Yes. Thank you, sir.
You need a microphone, don't you?
No, you want.
I am an established case of heightened vagal tone. That is, my heart can take 35 beats and 135 beats, since I am a sports person. And also I am an established case of bradycardia for the past 15-20 years. And one doctor suggested, that is a cardiologist, you should have pacemaker. But the electrophysiologist expert available in India, he told me, you don't need a pacemaker since you are a heightened vagal tone, your condition is called. But the head injury I had 28 years ago, now troubling. That is, at times I am getting some giddiness, and at times I feel some pain in the head, and it was not troubling so much for the past so many years. It was actually incurred in 1987, now 2015, and nearly 27-28 years ago. So is it advisable to go for any correctional surgery or to leave it with exercise and light medicine itself, sir?
Thank you, sir.
You've given us a very good description, but clearly one doesn't know the fine details of your case, and therefore it would be very difficult to in a way give any form of medical judgment on it. But one thing is good. You said you had it in 1987, is that right? And we're now looking at 25 plus years, as it were. So the fact that you look pretty well, you're standing up upright, so your autonomic nervous system must be working okay, as it were, or parts of it. My view would be, why worry if you're not being impaired in any way? But I must say, I'm doing this as a minor opinion rather than anything else.
If I may say so, sir, you're neither a falling man nor do you have failing neurons. And with that, I think we should bring the program to a close. May I invite Professor Krishnamurthy Srinivas to give formal thanks.
Should I sit down?
I think you can give it from here. I don't think they should. You can give it. He insists on coming up. He insists on for neurodians also.
It's my pleasant task to propose the Thanksgiving. First, I'd like all of you to give a standing, thunderous ovation to the Srinivasan family. Thank you. Next, unfortunately, I have to make you stand up again for Professor Christopher Mathias, the orator.
I'm sorry. Thank you.
John Milton said the world is only for those who stand and wait. Now, I want to thank the TVS Motors staff and Sundaram Clayton staff, especially Mr. Lakshmanan and Bala, who have been in the background and helping us with this program. And we've been constantly nagging them, but their answers are always in the positive. So please give them a clap. I want to thank Lalita Rai and Marindishwara Enterprises for the background arrangements that they have made, all the photographers, the staff of Grand Chola, our own staff, and all the others who have helped us. And there can never be a successful oration or any lecture without an audience, so I'd like to thank the audience for participating. I'd like to end this by Sir Robert Hutchison's two quotations. Robert Hutchison was one of the greatest physicians of the United Kingdom, and I met him in 1959 on my way to Canada. He died in 1960. He presented me with a lecture that he gave called 7 Gifts for All of You to the final year class at University College Hospital, London. He said, imagine I'm a fairy and I want to end out 2 gifts, and that is what I want to repeat to the younger generation here. The first gift is good health right through your career, not made in the jogging fields and gymnasiums of the United Kingdom, but given by God. Protect yourself adequately. Second is good luck in whatever you do, because without luck you can't succeed. And the final thing he said was, you students sitting in the front row who have won all the medals today, remember you may not be the most successful in life, because there's a fellow sitting in the back row who's reserved his engines for a later date. And finally he said, some brains but hard work, and justice to your patients, and medicine, have a bit of fun, enjoy yourself, because medicine is an ugly subject and can cause all kinds of problems. The other thing I'd like to say is that in The Art of Speaking and Writing in Medicine, written by Stephen Hawking, I congratulate Grand Chola in one way, because he said there should be 2 doors through which people could surreptitiously escape in darkness. And they've made the hall adequately that way. And finally, I would like to say that a speaker should cultivate brevity with a leaven of levity, for nothing is worse than interminable longevity. A Dickinsonian quotation. Thank you very much.
Thank you. Pleasure to have you here.
So I think we conclude now.
Please join us for high tea, which is served right behind, in the hall behind. The door will open in a moment.
One of the most